Welcome back to the deep dive. Today, we're taking a really dense stack of pathology sources and distilling them down to what you really need to know.
We're tackling the male genital system, penis, prostate, and testes. And this material can be incredibly heavy. Lots of jargon, lots of microscopic details.
And that's exactly why we're doing this. It's so easy to get lost in the weeds with, histological definitions and all the molecular pathways. So our mission today is really about precision.
Right. We want to extract the critical information. We're talking about the key diagnostic features, the molecular pathways that actually kick these diseases off, and maybe most importantly, the grading systems.
Yes, things like the Gleason score, which literally determine a patient's entire treatment path.
Exactly. So if you, the listener, need to get a fast handle on what truly matters in these pathologies, this is the breakdown for you. We're going deep on the details that define disease.
All right, let's get into it. I think we should probably start with the pathology of the penis. Where do we begin? Maybe with something fairly common, but really important because of where it can lead.
Genital warts, known in the literature as condyloma acuminatum.
And the descriptions, the visual descriptions in the sources are just so striking. They use phrases like cauliflower-like growth.
Or red velvety excrescent lesions. The gross appearance is certainly memorable.
But that's not the real story, is it? The real pathology is happening at a much smaller scale.
Exactly. It's a viral hijack happening at the cellular level. The risk factor here, as most people know, is HPV, the human papillomavirus.
Specifically the low-risk types for this condition, right?
Right. We're talking about HPV 6 and 11. Now, they usually just cause these benign warts, but understanding the mechanism, the way they work, is absolutely essential. It's like a blueprint for how the high-risk viruses drive cancer.
Okay, so this is where it gets into some serious cell biology. It's not just that a virus is present, it's what the virus is actively doing to the cell's security system.
It is a sophisticated biochemical attack. To get it, we need to focus on two specific viral proteins that HPV makes. They're called E6 and E7.
E6 and E7. And what are they targeting?
They're targeting the cell's ultimate gatekeepers, two proteins called P53 and retinoblastoma protein, or ARB.
These are the big ones, the tumor suppressor genes.
The absolute final line of defense. Think of P53 as the chief of internal security for the cell. If there's DNA damage, P53 slams on the brakes. It stops the cell cycle, tries to repair the damage.
So if it can't be repaired?
It triggers apoptosis, programs cell death. It tells the cell to self-destruct for the good of the organism. If P53 is working, a damaged cell doesn't become a cancer cell.
Okay, so that's P53, the damage control chief. What about ARB, the retinoblastoma protein?
ARB is the primary brake pedal on the cell cycle itself. Imagine the cell as a car ready to go. ARB's job is to keep that brake pressed firmly down until all the signals are green for a safe and appropriate division.
So you have the damage control officer, P53, and the main brake, RB. They're designed to stop uncontrolled growth.
Exactly. So now think about what the HPV proteins do, E6 and E7. It's a targeted, two-pronged attack.
And it just dismantles this whole defense system.
Completely. E6 hunts down P53, binds to it, and inactivates it. Gone. The cell loses its ability to spot damage and self-destruct.
Wow. Okay.
Then at the same time, E7 hunts down the RB protein and inactivates it. So the brake pedal is released. The cell is now free to proliferate uncontrollably.
You lose the alarm system and you lose the brakes.
That's the perfect analogy. And that joint inactivation leads to uncontrolled cell proliferation. In the case of low-risk HPV, that's warts. But with high-risk HPV, that's the direct path to invasive cancer.
That is just such a clear explanation of how a virus can cause cancer. It's not magic, it's targeted sabotage.
It is. Now, when a pathologist looks at a tissue sample of a wart, they're looking for the microscopic hallmark of this exact process. They're looking for a specific type of cell.
And that would be the coilocyte.
The coilocyte. It's the smoking gun for HPV infection.
What does it look like? What makes it so unique?
Well, it's a large polyhedral epithelial cell, but its defining feature is a large, dark, irregular nucleus that's surrounded by this clear space. It's famously called the paranuclear halo.
A halo around the nucleus.
Yes, and that clearing is caused by the viral proteins messing with the cell's cytoplasm. The pathologist will also see a general thickening of the epithelium, which we call acanthosis, and a buildup of keratin on the surface, or hyperkeratosis.
But it's that coilocyte with the halo that screams HPV.
It's the pathognomonic sign, yes.
Okay, so let's move up that risk ladder now. From the benign warts to the pre-malignant lesions. The sources lay out three very distinct tiers here.
And this is so important clinically because they sound similar, but their prognosis is worlds apart. We're talking about Bowen's disease, Bowen papulosis, and erythroplasia of Poirot.
Let's start with Bowen's disease. The sources say it's usually a solitary lesion, and it's typically seen in the elderly.
Right. And that demographic, the older age group, combined with the fact that it's a single persistent lesion, that immediately raises the level of concern.
And the risk of it progressing to cancer is quite high.
It's significant. The sources state there's a 10% risk of progression to invasive squamous cell carcinoma. 1 in 10. That's a number that demands aggressive management.
Okay, now let's contrast that immediately with Bowen papulosis. The name is so similar, but the clinical picture is totally different.
It really is the perfect low-risk contrast. Bowen papulosis presents as multiple little papules, and you see it in a completely different population, young, sexually active individuals.
And critically, the risk of cancer is low.
Very low. And what's more, a large percentage of these cases just regress spontaneously. They go away on their own. It just shows you how important the patient's age and the lesion's appearance are.
And the third one, erythroplasia of Poirot. This one is really defined by its look, right?
Yes, it's all in the name. It presents as these vivid red papules on the penis, usually on the glans. It's also considered a premalignant lesion, a form of carcinoma in situ.
Meaning the cancer cells are there, but they haven't broken through the basement membrane yet. They haven't invaded.
Exactly. The potential is there, but it hasn't happened yet.
Which brings us to the full-blown malignancy. Squamous cell carcinoma, or SCC, of the penis. This is where those precursor lesions can lead. Typically, we're looking at men in the 40 to 50-year range.
Yes, and the location is often on the shaft of the penis. The risk factors are, well, they're pretty consistent with what we know from public health. Poor genital hygiene is a big one.
Often linked to not being circumcised, which can trap irritants and pathogens.
Right. And then, of course, that's compounded by infection with the high-risk HPV types. We're not talking 6 and 11 anymore.
Now we're talking 16 and 18.
We're talking 16 and 18. They are just far more efficient at taking out P53 and ARB. They are the primary drivers of the invasive malignancy itself.
So when a biopsy is done and the pathologist is looking at it, how do they tell the difference between a less aggressive, say, a well-differentiated SCC and a really aggressive, poorly differentiated one?
It all comes down to how much the tumor cells still look like the normal squamous tissue they came from.
So if they still look somewhat normal, they're well-differentiated.
Exactly. A well-differentiated SCC still tries to do its job, which is to make keratin. And this shows up under the microscope as these beautiful structures called keratin pearls. They're like little world nests of keratin.
So the presence of keratin pearls is a good sign, relatively speaking.
It's a sign that the cancer hasn't completely lost its mind, yes. But as it becomes more aggressive, more poorly differentiated, it loses that ability.
So no keratin pearls.
No keratin pearls. You just see disorganized sheets and masses of ugly-looking cells. The architecture is gone.
But even in the poorly differentiated ones, is there one thing, one cellular feature, that still tells the pathologist, yes, this is definitely squamous?
There is. You can still see the desmosomes. These are the little physical bridges, the junctions that hold squamous cells together. Even in aggressive cancers, you can usually still spot them between the cells.
And you can confirm that with special stains, right, with IHC.
Absolutely. Immunohistochemistry, IHC, is how we get definitive proof. We use antibodies tagged with a stain to light up specific proteins in the cells. For squamous cancers, we look for markers like P40 and P63.
So if the cells light up with P63, you know you're looking at a squamous cell that's gone rogue.
That's exactly it. It's a molecular confirmation.
Now, there's one specific subtype of FUC we have to mention, verrucous carcinoma.
Yes, this is a really important one to know about.
Because its prognosis is completely different from a typical SCC.
It is. Verrucous carcinoma has an excellent prognosis. And that's because, despite looking very large and warty on the outside, its growth is very organized, and, critically, it stays very superficial. It almost never metastasizes. It's the exception that proves the rule.
A fantastic distinction.
Yeah.
Okay, that's a great deep dive on the penis. Let's transition now to the prostate gland. This is a whole different world of anatomy and hormones.
It really is. Shifting gears to the prostate. It's a small organ, normally about 20 grams, like a walnut. But its internal anatomy, its zones, are the single most important thing to understand about its diseases.
The zonal divide. This concept seems to dictate absolutely everything.
It does. It determines when symptoms appear, and it often determines whether a lesion is benign or malignant. We need to focus on two main zones from the sources, the transitional zone and the peripheral zone.
Okay, let's break that down. The transitional zone.
The transitional zone is the central part of the prostate. It's the part that wraps directly around the urethra, the tube that urine flows through.
So anything that grows there is going to cause problems pretty quickly.
Immediately, any expansion of that tissue squeezes the urethra. And this is why the transitional zone is the site of benign prostatic hypertrophy, or BPH.
And because it's pressing on the pipe, the symptoms like difficulty urinating, getting up at night, they appear really early.
Exactly. They're what we call lower urinary tract symptoms, or LUTS, dysuria, nocturia, frequency. They're unpleasant for sure, but they get the patient to the doctor early.
But the more dangerous disease, the cancer, that happens somewhere else entirely.
Yes. Prostatic adenocarcinoma develops in the peripheral zone. This is the outer posterior part of the gland, far away from the urethra.
Which means it can grow silently for a very long time.
For a very long time. The symptoms appear late, which delays the diagnosis, and that delay is why prostate cancer so often has already metastasized by the time it's found. It's a cruel trick of anatomy.
BPH shouts at you, but cancer just whispers until it's almost too late. That's a vital distinction.
And just one more marker to lock in before we dive into BPH. The marker for the myoepithelial layer, that basal layer of cells in the glands, is P63.
And we're going to see why the presence or absence of that layer is the absolute key to telling benign from malignant.
It's the whole ball game, microscopically.
All right, let's tackle BPH itself. Benign prostatic hyperplasia. The sources are very clear on 2 points right up front.
First, it is by far the most common prostatic disease, Maxio, as we say. Second, and this is critical, it is not a pre-malignant condition.
So having BPH doesn't mean you're more likely to get prostate cancer.
Correct. They are two separate disease processes that happen to occur in the same organ. BPH is just a benign overgrowth, mostly affecting elderly men.
And what does it look like, grossly? How big does the prostate get?
It can swell up significantly. From 20 grams normally, it can get to 60 or even 80 grams, a 3- or 4-fold increase. And when you slice it open, it's described as white and very nodular. You can see and feel the nodules of overgrown tissue.
So what's driving this growth? It's hormonal, right?
It's a very specific hormonal pathway. Testosterone circulates in the blood, and it gets taken up by the stromal cells in the prostate.
The connective tissue cells.
Right. And inside those stromal cells is a key enzyme called 5-alpha reductase. Its job is to convert testosterone into a much, much more potent form.
And that is DHT.
Dihydrotestosterone, DHT. It is the superfuel for prostate growth. It's DHT that stimulates the hyperplasia, the overgrowth of both the glands and the stroma in that transitional zone.
So DHT is the villain here. And understanding that pathway leads directly to one of the main treatments for BPH.
It does. The drug finasteride is a 5-alpha reductase inhibitor. It blocks that enzyme.
So it cuts off the conversion of testosterone to DHT.
Exactly. You reduce the amount of the growth-driving DHT, and the prostate can shrink or at least stop growing, and the urinary symptoms get better. It's a beautiful example of a targeted molecular therapy.
So what does BPH look like under the microscope? What are the key features?
You see hyperplasia of both glands and stroma. Architecturally, a key feature is papillary infolding. The lining of the glands grows into the lumen, creating these complex folded patterns.
And what's the one feature that tells you for sure that it's benign?
It's the presence of that myoepithelial layer, that basal cell layer. A benign gland always has 2 layers of cells. If that outer myoepithelial layer is intact, it cannot be invasive cancer.
So that P63 stain we mentioned.
You stain for P63, and in BPH, that outer layer lights right up. It's a definitive sign of a benign process. We also often see these things called corpora amylaceae, which are just calcified secretions inside the glands, very typical for BPH.
Okay, that's a great foundation. That sets the stage perfectly for the malignant threat. Prostatic carcinoma. Let's start with the risk factors. The demographics here are pretty stark.
They are. The biggest non-modifiable risk is just age. This is a disease of aging. Second is a really unfortunate and well-documented racial disparity. It's more common and more aggressive in Black men than in white men.
And a major modifiable risk.
A high-fat diet is consistently linked to increased risk.
But the sources also provided a counter-narrative, some specific dietary factors that seem to be protective.
Yes, and this is fascinating. They specifically mention lycopene, which is the pigment in cooked tomatoes, also selenium, soy products, and vitamin D.
Interesting. And what about genetics? What are the key genes involved?
2 really stand out. First, mutations in the BRCA2 gene on chromosome 13. We usually associate BRCA with breast cancer, but it's a major risk factor for aggressive prostate cancer, too.
And the second one is a kind of fusion gene.
Yes, it's a chromosomal rearrangement that creates something called the TMPRSS ETS fusion gene. This is found in about half of all prostate cancers. It's a major driver of the disease.
Now, we already said the symptoms are late because of the peripheral location, so when the disease finally does show itself, it's often because it has spread.
That's right. And it has a strong preference for spreading to bone, bony metastases.
And these are specific type of bone lesion, right?
Yes, they are osteoblastic. That means they cause the bone to grow and become more dense, which is different from many cancers that cause osteolytic or bone-destroying lesions. These osteoblastic secondaries most often hit the lumbar spine.
Which presents as.
Chronic low back pain. For an older man, persistent low back pain is a major red flag for metastatic prostate cancer.
Microscopically, how do we define adenocarcinoma? How is it different from BPH?
It's all about architecture. Instead of big open glands, you see lots of small glands packed tightly together, back to back, with very little stroma in between.
And the most critical feature.
The absolute definitive absence of the myoepithelial layer. That basal cell layer is gone.
So if you do that P63 stain.
The cancerous glands will be negative. The basal layer is gone, which is what allowed the cells to become invasive in the first place.
Okay, let's talk markers. The most famous one, of course, is PSA, prostatic-specific antigen. You made the point earlier that it's organ-specific, not cancer-specific.
A crucial distinction. PSA can be elevated for lots of reasons. BPH, inflammation, infection, and yes, cancer. That's why just looking at a single PSA number isn't enough.
So how do we make the number more useful? What are the other metrics we look at?
We refine the data. We look at the ratio of free PSA to total PSA. Cancer tends to produce less free PSA. We also calculate PSA density, the PSA level divided by the volume of the prostate gland. A high density is suspicious.
And the rate of change is also important.
Hugely important. That's PSA velocity. A normal rate of change is less than 0.75 nanograms per milliliter per year. If it starts rising rapidly, even from a low number, that's a major red flag.
And the sources give specific age-adjusted cutoffs for what's considered suspicious.
Yes, because a man's baseline PSA naturally goes up with age as the prostate grows. So for a man in his 40s, a PSA over 2.5 is concerning. But for a man in his 70s, the threshold is higher, over 6.5. It's about context.
Are there any other markers beyond PSA?
Historically, we used prostatic acid phosphatase, or PPE. But now we have newer molecular tests like PCA3 in the urine that are more specific and help clarify ambiguous cases.
The pathology report also often mentions something called perineural invasion. What is that and why is it so important?
Perineural invasion is a very bad sign. It means the cancer cells aren't just growing randomly, they're actively tracking along nerve sheaths. They're using the nerves like highways to escape the prostate.
So it's a sign of very invasive, clever tumor.
Exactly. It's a strong predictor of extracapsular extension and a factor that pushes towards more aggressive treatment.
Okay, this brings us to the absolute core of prostate cancer pathology. The Gleason score. This is what it all comes down to for prognosis and treatment.
It is. The Gleason score is based purely on the architecture of the tumor, how the glands are arranged. The calculation is the score of the primary, most common pattern, plus the score of the secondary, second most common pattern.
And these patterns are graded from 1 to 5, with 5 being the worst.
Correct. Pattern 1 is the best differentiated. The glands are small, uniform, and look almost normal. As you go up, the architecture breaks down.
What does a pattern 3 look like?
Pattern 3 is where you start to see distinctly infiltrative margins. The glands are still there, but they're starting to invade the stroma irregularly.
And pattern 4 is a big jump up in aggression.
It is. This is where you see irregular masses of glands, or they're fused together. Pattern 4 is also associated with the cribriform pattern, which looks like the tissue is full of holes, like a sieve. Very aggressive.
And pattern 5 is a total loss of organization.
Total loss. You see sheets of cells with no gland formation at all. Pattern 5 is also where you might see chromatonecrosis, which is central areas of cell death within the tumor masses. The tumor is growing so fast it's outstripping its blood supply.
So you add the primary and secondary patterns together to get a score, which traditionally ranges from 6 to 10. but that's been confusing.
Very confusing for patients. A score of 6 sounds bad, but it's actually the lowest possible score. So a newer system was developed.
The grade group system, from 1 to 5, this is much clearer.
Much clearer. So grade group 1 is only a Gleason score of 3 plus 3 equals 6. This is the best prognosis, often managed with active surveillance.
Okay, and grade group 2.
Grade group 2 is a Gleason score of 3 plus 4 is 7. That means it's mostly the better-looking pattern 3 with less of the more aggressive pattern 4.
And this is where the crucial distinction comes in. Grade group 3 is also a Gleason score of 7.
But it's 4 plus 3 equals 7. This means it's predominantly the more aggressive pattern 4 with less of the better pattern 3. Even though the sum is the same, a 4 plus 3 is significantly more aggressive than a 3 plus 4.
Because the dominant pattern is worse. That is such a critical point.
It's everything. Grade group 4 is a Gleason 8, and grade group 5 is a Gleason 9 or 10, which is the worst prognosis. And just to round it out, the IHC marker that's often positive in prostate cancer is AMACR.
Wow. Okay, that was an absolutely essential breakdown of the prostate. Let's shift gears for our final section and move to the testes. This involves some really different concepts.
A completely different set of diseases. Before we get into the tumors, it's just helpful to remember the normal histology. You have the seminiferous tubules, where sperm are made, and then the Leydig cells in the tissue between the tubules, which make hormones.
And the first major issue is a developmental one, cryptorchidism.
Right, the failure of a testes to descend into the scrotum.
And the most common place for it to get stuck is where?
In the inguinal canal. But the really critical thing about cryptorchidism is that it massively increases the risk of developing a testicular tumor later in life.
Why is that? Is it the heat?
It's the temperature. The inside of the body is too warm for proper sperm development. That constant higher temperature causes damage and atrophy in the seminiferous tubules. You see a complete loss of spermatogenesis. And that environment of cellular stress is what predisposes it to malignancy.
And there's a specific precursor lesion for most of these tumors?
Yes, it's called intratubular germ cell neoplasia, or ITGCN. It's the in situ stage with malignant cells confined inside the tubules.
It's the precursor for most, but not all, germ cell tumors.
Correct. The sources are clear that spermatocytic seminoma and teratoma are the exceptions. They do not arise from ITGCN.
Okay, so risk factors for testicular cancer include cryptorchidism, family history, and some genetic conditions like Klinefelter syndrome.
And environmental exposures like pesticides are also implicated. Clinically, the #1 presentation is a painless enlargement of the testes.
And because it's painless, men often delay seeking help.
They do, which leads to a really important clinical rule. The sources state that a needle biopsy, or FNAC, is absolutely contraindicated for a suspected testicular mass.
Why is that?
Risk of tumor seeding. The lymphatic drainage of the testes is different from the scrotum. If you stick a needle through the scrotum into the tumor, you can spread cancer cells locally or change the drainage pathway, which makes staging a nightmare.
So what's the proper procedure?
A high inguinal orchidectomy. The entire testes and spermatic cord are removed through an incision in the groin, keeping the scrotum intact.
Fascinating detail. Okay, let's get to the main classification. Germ cell tumors are split into two huge categories.
Seminomatous and non-seminomatous. And this distinction is everything for prognosis and treatment.
What's the general rule?
The general rule is that seminomas have a better prognosis, and they are extremely radiosensitive. They melt away with radiation.
And non-seminomas.
Poor prognosis, generally. They are radioresistant, but they are often chemosensitive, so they require intensive chemotherapy.
Let's focus on seminoma first. It's the most common one in adults.
Most common testicular tumor, period. Usually in men aged 20 to 30. Good prognosis, painless lump.
And what does it look like when you cut it open?
It has a classic description. A cut potato appearance. It's just a uniform, white, homogeneous mass. And critically, it doesn't have the hemorrhage and necrosis you see in the more aggressive non-seminomas.
What about tumor markers for seminoma?
It can be positive for PLAP, OCT34, and CD117. And HCG can be slightly elevated sometimes. But the absolute rule for a pure seminoma is that AFP, alpha-fetoprotein, is never raised.
If AFP is up, it's not a pure seminoma.
It means there's a non-seminomatous component and the whole game changes. Microscopically, seminoma has the classic fried egg appearance. Large cells with clear cytoplasm arranged in nests, separated by fibrous bands that are full of lymphocytes.
Okay, now for the non-seminomatous tumors. More aggressive, different markers. Let's run through the main subtypes.
First up, the yolk sac tumor.
The age profile here is completely different.
Completely. This is the most common testicular cancer in infants and children under 4 years old.
And its marker is AFP.
Yes, AFP is the classic marker. And under the microscope, it has a pathognomonic feature, the Schiller-Duval body. It's a structure that looks like a tiny, primitive glomerulus. When you see it, it's a yolk sac tumor.
Next, choriocarcinoma. The description says highly aggressive.
Incredibly aggressive, often presents with widespread metastases already, especially to the lungs, what they call cannonball mets. It's full of hemorrhage and necrosis, and its tumor marker is a sky-high beta-HCG.
And microscopically, it's made of the two cell types from the placenta.
Yes, you see both the cytotrophoblasts and the big multinucleated syncytiotrophoblasts. That's what defines it.
Then we have the teratoma. This is one that can have different kinds of tissue in it.
Exactly. It's derived from all three germ layers, so grossly you can find things like hair, cartilage, bone, even fully formed teeth inside the tumor.
And its behavior depends entirely on the patient's age.
It does. In a prepubertal boy, a teratoma is considered benign, but in a postpubertal adult, it's considered malignant and has the potential to metastasize.
And the last of the big four non-seminomas is embryonal carcinoma.
Right. This is a bit of a diagnosis of exclusion. It's made of very primitive, ugly-looking cells. It's less organized than a seminoma, but doesn't have the specific features of the others. Its key IHC marker is CD30 positive.
Let's quickly wrap up with the other two main categories of testicular tumors. First, the sex-cord stromal tumors.
The main one there is the Leydig cell tumor. It arises from the Leydig cells, so it's often hormonally active. It can secrete androgens and even estrogen,
Which can cause precocious puberty in boys or gynecomastia, breast development, in men.
Correct. And its microscopic landmark is the presence of Reinke's crystals, these little rod-shaped inclusions in the cytoplasm. It's also positive for a marker called inhibin.
And finally, testicular lymphoma. Again, a very specific age group.
Yes. This isn't a germ cell tumor at all. It's the most common testicular malignancy in elderly men over the age of 60.
And it's usually a specific type of lymphoma.
Usually diffuse large B-cell lymphoma, and because of the age of the patients and the aggressive nature of the disease, it carries a very poor prognosis.
This has been an incredibly thorough journey. I mean, from a single viral protein all the way to complex grading systems. Before we sign off, let's just pull out some of the most striking high-yield facts.
I agree. It's a lot to take in, so let's anchor the key points.
For me, back in the penis section, the thing that really clicked was seeing how HPV's E6 and E7 proteins were like a two-key system to unlock disaster. Taking out P53, the alarm, and ARB, the brake. That's just such a clear mechanism.
And for the prostate, it has to be the anatomy, that zonal divide, BPH in the central transitional zone causing early symptoms.
Right.
While cancer grows silently in the outer peripheral zone, often presenting late with that classic low back pain from osteoblastic bone mets, that's a story every clinician knows.
And the Gleason score, the nuance that a 4 plus 3 is worse than a 3 plus 4, even though they both equal 7. That's a perfect example of how pathology is more than just numbers. It's about the dominant pattern.
Absolutely. And with the testes, it's that fundamental split. The seminomas, good prognosis, radiosensitive, never have high AFP. And the non-seminomas, more aggressive, radioresistant, and linked to specific markers like AFP or HCG, knowing that binary split is half the battle.
You know, when you put it all together, the IHC markers like P63, the genetic fusions like TMPRSS, ETS, the microscopic landmarks like the Schiller-Duval body, it really shows how diagnosis has moved from just a general observation to this incredibly targeted, molecularly informed science.
It does. It underscores why these classifications matter so much. The tumor markers, PSA, AFP, HCG, they're not just abstract numbers. They are real-time signals of the disease. And when you combine them with the Gleason grade group, you can create a highly specific, personalized plan for the patient.
Which brings us to a final thought. The sources highlighted very specific protective dietary factors for prostate cancer, things like lycopene and selenium, right alongside very specific genetic risks, like BRCA2 mutations.
So it raises a really provocative question for the future. How could this level of detail transform preventive screening? We're moving past just using broad categories like age.
Right, we're entering an era of personalized molecular and lifestyle profiling.
Exactly. So if we know a man has a genetic predisposition to aggressive disease, and we also know the specific dietary changes that could offer protection, how long before we start integrating that? Will we move from just reactive PSA testing to creating these hyper-personalized risk profiles to manage and intervene long before grade 5 malignancy ever develops? That's the real power hidden in all this pathological detail.